Thank you very much. We already have heard some of the guidelines, and actually it has become clear for most of us that an adequate RV function is very important to have a good long-term result. However, there are many residual lesions. There are problems in the muscle, partly because of the disease itself, partly because of everything that the surgeon did. There is problems at the outflow tract with residual gradients, regurgitation, problems at the tricuspid valve, either primary or secondary, problems within the lung system. All things that will put an extra burden, an extra volume and pressure overload onto the ventricle. Extra burden means excess wear. Excess means premature complications, premature death. And so the key question that we have to answer is, let's assume that a normal RV is good for you, and that's what evolution has told us. How far can you deviate from normal? And in order to answer that question, you have to answer the most important question of all. Actually, what is the end goal of our treatment? Now, if you ask that question to an arrhythmologist, he will say, yes, if you avoid VT, that's it, and that's good. Then, of course, for how long? Or if you ask it to the clinician, what is the end goal? Have good exercise level, and then again, for how long? Or survive, and then again, for how long? I think if you would ask a patient, what is for you important? Well, I presume, and most of my patients do, that their answer will be that they have a cardiac symptom and event-free life for about 8 decades. That is the end goal, full stop. Every measure that we take should be measured against this end goal. All the rest, as far as I'm concerned, are surrogate endpoints. Because obviously this end goal has one major problem. If you do something today, you need to wait 70 to 80 years to know the result, and that's way beyond what most of us can handle. So if we are going to allow some degree of dysfunction, what is too much? And then we should go and look at all the studies that do describe RV overload and real long-time survival. And now I mean with long time, I really mean long time. In some of the papers, some people already consider long-time follow-up 2 years. No way. Long time for me means 70 years, 80 years, because that's what our patients want. And so what do we find in the literature? Nothing. Full stop. So in other words, whatever guideline you're going to hear, either from me or in the slides or whatever, be aware, none of these guidelines so far has proven or has stood the test of time. None. So those guidelines are supposed to guide us. It's not the Word of God. It's not the Quran. It's not the Bible where those lines are written. It is something man-made because we don't understand even what's going on for the time being. So the point I want to make is there is no single report with the real endpoint being good survival up to 80 years of old. All the other reports are with surrogate endpoints, and then of course the key question is, how good is your surrogate endpoint in predicting the real endpoint? And again, nobody will answer that question. For sure, it's going to be a balance between if we are going to replace the pulmonary valve, because that's the main issue of this symposium. On one hand, we don't want to do it too late, because there are many problems of dysfunction, arrhythmia, and even premature death. And not too early, because you don't want to do a procedure, always there will be some risk. You know that there will be problems with the conduit. We just heard results of the surgical conduits, and by far they are no good. I mean, 10 years is nothing. And repeated replacements, if you do it too early, what does that mean on number of procedures on a lifetime? And the general question we have to ask ourselves, what do we do in medicine? Why do we do a procedure? Why do we do an operation? Why do we do an intervention? Well, typically there is two things. First of all, there need to be an indication, and then there is the issue of the timing. When do you do it? The indication must be if there is a lesion that will limit your life or limit the quality of life, most of us will agree you need to do something about it. That's what we do in medicine. When do you do it? Well, that will completely depend on many factors. They are all enumerated over here. The natural history of the disease. So for instance, prostate cancer, which 70% of all the males will have by the time they're 75 years old, we don't start treating that at the age of 20 for the simple reason that natural history is only much later. Are they symptomatic? Is there damage, but can it be reversed? If there is a procedure, what are the possibilities? What are the risks? Very important. Possible complications. The patient is important. Cost reimbursement. What is the cost for the patient? What is the cost for the society? After the procedure, if you do the procedure, is the unnatural history better than the natural history? We know there will be complications, dysfunction, outgrowth. There will be reoperations with increasing complexity. So all these factors will determine what if we're going to do and when we're going to do it. Now allow me to make a small intermezzo. And what do we know, for instance, about ASDs? When do you treat an ASD? I think that all of us will agree that if any of these things will occur in a patient with an ASD, you're way too late and you missed the train. Also for this, if there is irreversible dysfunction, dilation, hypocontractility, electrical instability of atrium or ventricle, too late. Shall we close an ASD if we know that that ASD has no chance anymore of closing? For instance, we will not close an ASD in a 1-month-old child because we all know the majority of those openings will close by themselves. But at the age of 3 years or 4 years, then most of us will become certain that that ASD will not close. Or shall we further postpone it until there is no more gain, either in safety, scar, risk, benefit, whatever? And one special thing about ASD is, after we close it, typically the follow-up will be normal. Okay, there may be erosions and things like that, but I mean, usually it's normal. And that's the kind of graph that I like to work with in my mind. If this here is RV function over time, and so it stays good until old age, and typically RV function will not be the limiting factor for the elderly person. If there is an ASD, we know that there is a progressive decline in RV function, and in the 4th, 5th decade, the patient will become symptomatic. In the old days, the 60s, the 70s, you did treat ASDs typically at an age where you were assured this patient is going to run into trouble. However, patients never resumed complete normality, and also you got a honeymoon for 1 or 2 decades and got again into trouble. What do we do nowadays? Even before that patient has any problem whatsoever, we close the ASD and we expect him to have a normal life expectancy. So, what do we learn from all this? That if the natural history of a lesion is unfavorable, and if deferring treatment can deteriorate the late results, so there is a time, if you're too late, you missed the boat. But if the point of no return is unclear, so that means you don't know exactly when that irreversible damage is going to occur. But if the treatment, your intervention has a risk of nearly 0, and the follow-up after that treatment is good, what do we do with ASDs? Well, typically we will treat them very early on, even if nothing bad happens. And let's be honest, some patients will get an ASD treatment of whom we by far are not sure that they ever really would need it. I don't say that's good management, but that's the way it is nowadays. What do we know from volume overload? Well, if you get, there are several stages, we think. Actually, it's what happens to the left ventricle, but I presume that you can say more or less the same thing from the right ventricle. If there is a mild to moderate degree of chronic volume overload, the ventricle will become bigger, it will become more compliant, there will be more hypertrophy, so that the stress in the muscle will remain normal. This is what we call a sports heart. Sport is good for you. That's what we like, completely physiologic. However, if it's a little longer or more, there will be more dilation, inappropriate hypertrophy, so more stress, mass to volume will decrease. Ejection fraction may decrease, but intrinsically the muscle itself still is all right. And we have the feeling that this is all right, at least for 10-15 years. In the long run, I'll come back to that. If the volume load is even worse, then we will see that contractility really will go down, architecture, the ventricle will become more globular, and if it's even much worse, there will be cell death, fibrosis, collagen replacement. Here everybody agrees this is bad. This is probably bad, so something in between, we think that's where we should be. And indeed, if you look at patients who have isolated pulmonary regurgitation, so no postoperative patient, patients isolated pulmonary regurgitation, nobody touched them, what do you see? Those guys get a honeymoon period of 3-4 decades and then a steep decline with, if you count any complication that they may have. And so from there came then the feeling you don't want to do it too early because you saw the surgical results on valve replacements are not that good. I mean, 10 years of good conduit function is reasonable, but I mean, if you get your first replacement at the age of 20 and you want to reach 70, 80 years old, that means 7 operations. Thank you. Dalgiva from the Boston group, they every 5 years they get new recommendations that are the ones from 2006. We'll discuss the ones from 2013 in a second. But big heart, and it used to be 170. Here in 2006 it was 160. The latest in it's now 150. So they're feeling that there is something not very good, some mechanical things. If there is a big aneurysm, symptoms. If the patient is symptomatic, most likely you're too late. If the patient has syncope, we all know a syncope may be a missed sudden death. I mean, if you wait for syncopes, it's bad, very bad, you're way late. Of course, this also bad. There is nothing you can do about that. And then also if you read the paper of Dalgiva, his guidelines prediction, so what does he base these numbers on? Well, if you operate a patient within these guidelines, what does he promise you? Does he promise you that you will reach your 80 years old? No way. He will tell you that there will be some regression of the RV dilation, some recuperation of RV function. That's all he promises, no more, no less. Yeah? Well, most of our patients, at least my patients, they are not interested that they have an organ that can shrink. Again, I said what they want to have is event-free survival up to 80 years old. So it sounds good. Yeah, I mean, there is definitely probably some value to it, but it's not the end of the world. So what do we know from Gazoulis? You already saw that slide. Pulmonary regurgitation is bad. It is associated with ventricular arrhythmia. It is associated with sudden death down the line. And so, what are the guidelines? I think for stenosis, it's not a major issue. First of all, it doesn't kill you. So a gradient of 50 or 60 apparently is well tolerated and it will not add too much to mortality. But these patients beyond 50 millimeters of mercury all will become symptomatic. They will come to your office and say, I cannot do as much as I used to be able to do. They will demand something. So that is an easy solution. In pulmonary regurgitation, here if you stick to those rules, so we have rarely normalization. We have minimal change in maximum exercise capacity, partly because we may be too late already. How long is the freedom of VT and VF gonna be? It's not forever, for sure. Those patients, if you stay within these guidelines, they get another honeymoon period of 2 decades, and then the arrhythmologic people start working again. And about long-term survival, not a single word has been published yet. None of our patients that was operated in infancy has reached 70 years yet, because we only do the operations for 40 years. Yeah. That's another thing I like you to consider. As I said, everybody knows sports is good for you. Now in Belgium, we have a country with a lot of bikers. And what is bicycling? What does that mean for your heart? Bicycling, you use your quadriceps. Your quadriceps is your biggest muscle that you have. It will create the biggest volume load for your heart. And you can bicycle at least easily for 2, 3, 4 hours. Now, we have some fanatics, and they love to bike. They love to bike 1,000 kilometers a week, easily, for years. What do we see? That in that subgroup, also in the racers, the professional racers, we have athletes that present with symptomatic VT. Yeah, I think we all agree that that is not the most, and some of them drop dead. Yeah. Now, if we looked at a bunch of people like that. Here, normals, non-athletes without arrhythmia, in other words, us. By the way, look how big a normal right ventricle is. Most of you are not aware of that. The bikers that have a good heart, stable heart, no ventricular arrhythmia, well, that's a sports heart. Right ventricle, somewhat bigger, good contractility. And what do we see in those athletes that do present with ventricular arrhythmia? Somewhat bigger hearts, and if we look at contractility, severely depressed. What does this teach us? That if you sit on a bike for more than 10 years, 10 to 15 years, for more than 1,000 kilometers a week, you burn out your ventricle. Unhealthy. Now you are going to say, how does this compare to our fellows? Well, in a fellow, we demand from the right ventricle, if there is significant pulmonary regurgitation, that there will be an overload 24 hours out of 24 for so many years. And we see almost the same thing occur. It's a different degree of aggression, but with a similar result. So what do we know from the patients with pulmonary regurgitation? In the beginning, very well tolerated, but RV happiness, whatever it may be, mechanical or electrical, after 3 to 4 decades, we see that some trouble will occur. And so I already said in the 70s, the motto was no PS except any PR. We now know that it should be limited, and at one point it should be replaced. Now, if you stick to the very early protocols and wait until that ventricle is really huge, really big, okay, there will be some improvement, but all the conduits will go down. We now know you should do it a little earlier, but again, you will not reach normality, not with the current guidelines. And if you count here only 4 or 5 replacements, you will have a hard time reaching your 70 years old with a reasonable ventricular function. I already showed this, late mortality in every big series, here the Rotterdam group. This is the result of the current guidelines with ICD implantations. I mean, if a patient presents in ventricular arrhythmia, of course you read a lot of things. You can put an ICD, you can give antiarrhythmia and things like that. I think we as doctors, we as clinicians, it's much wiser to avoid this problem than to learn how to cure it. And so it started to emerge here from the Canadians, that pulmonary valve implantation in these patients should be considered before our dysfunction ensures. Again, here I think it's from the JAC, same thing where everybody has the feeling something is going wrong over here. If you wait long enough, there is a major problem. And so that's the question that we still need to answer, and we won't answer it today. We certainly will not answer it this year. When is too long? When is too much? These were then you already saw this slide. But look at the current recommendations. So that's Stalgiva 2013. What do we see here? Wait, what was it again? Severe branch. In the asymptomatic patients, it said something with arrhythmia. I mean, if those patients present an arrhythmia, it's bad. Here, signs and symptoms, dyspnea, edema. I mean, if you allow it to go that far, your heart is cooked, you're burned. Syncope attributable to arrhythmia. Again, syncope is the beginning of sudden death. This is way, way far. I think some of these of guidelines are amenable to improvement. So here is one end, and I think those guidelines, the current guidelines, do reflect on how far do we think you can go today before you really are in the red. I think these guidelines are already in orange. They are no longer in green. On the other hand, you can say, let's put in a valve once the outflow tract gets adult size. The advantage of adult size is that you can put with one valve if it lasts long enough, because we know at least for 1 or 2 decades it's good. It's definitely more physiologic. I can prove you, and I'll show you tomorrow or late this afternoon, that their exercise does improve. Does it avoid this? Well, it takes 20, 30 years before you can give a reasonable answer to that. Is it going to be better for survival? I don't know. I expect it to be better. Is it too good? Is this then too early? I don't know. We need 60 years, something like that, to determine the truth. The best optimal point will be somewhere in between these 2 points. And where should we move from here? I think we must remain critical. We must know that there are limitations to the current guidelines, and that is a problem. For instance, as I am exploring, many of you know some of my articles where I do put indeed valves earlier on. As we are exploring the borders, that is a frequent comment I always get from the reviewers is, "Wow, you're going out of the guidelines. You are a criminal." Hello, those guidelines are not dictated by God. There are guidelines to help us think, and apparently I think there is more and more evidence coming up that there are limitations and restrictions to these guidelines. I thank you for your attention.